A rare, deadly disease that leaves patients in critical condition and doctors searching for answers. Knowing the signs can save a life. This is Investigating HLH, a podcast about hemophagocytic lymphohistiocytosis brought to you by Sobi Inc.
Hello everyone, Adam Narloch here, and I'd like to welcome you back for episode 2 of Investigating HLH, a podcast about hemophagocytic lymphohistiocytosis sponsored by Sobi Inc. If you haven't yet, I'd encourage you to listen to episode 1, an introduction to HLH, with Dr. Michelle Hermiston, where she walked us through an overview of HLH and some of the mechanisms behind it. For this episode, we'll be talking about the diagnostic process for identifying HLH and the challenges associated with that. Joining us are two highly respected experts who've played a critical role in advancing our understanding and knowledge about HLH with their dedication to research and their caring for patients. Dr. Ashish Kumar is a pediatric hematologist-oncologist and director of the Histiocytosis Center at Cincinnati Children's Hospital. He specializes in histiocytic disorders, primary immune deficiencies, and bone marrow transplantation. He's always striving to give the best possible care for patients while improving our understanding of these complex conditions. Dr. Scott Canna is a pediatric rheumatologist and assistant professor of pediatrics at Children's Hospital of Philadelphia. He's also the founder of the Canna Lab, a group dedicated to uncovering fundamental mechanisms behind autoinflammatory and hyperinflammatory diseases, and using these discoveries to improve patient care. Both Dr. Kumar and Dr. Canna are experts in HLH, and I'm excited to hear them converse about the diagnostic process and the challenges they experience. So welcome to the podcast, Dr. Kumar and Dr. Canna, and thank you so much for joining us. If you'd like, please tell us a little bit more about yourselves and your experience with HLH. Let's start with you, Dr. Canna.
Okay. Where to start? I am a pediatric rheumatologist, and I'm done apologizing for it. I kind of got my teeth cut back in medical school. I kind of got interested in inborn errors of immunity and genetics, and then as a resident, learned about this entity called macrophage activation syndrome, which was the source of a lot of consternation, as I'm sure we'll get into later, and kind of have been trying to understand what is underneath the hood of some of these loaded terms, and in the process have gotten really sort of deep into the weeds of both the sort of semantics, the philosophy, the history of medicine of all of this thing that we call HLH, which I think is part of what makes it sort of mysterious or annoying, depending on your perspective. And then was pleased to be allowed / recruited back to Children's Hospital of Philadelphia in 2021 to be part of what we call our immune dysregulation program, which really started as an HLH response team many years ago and has kind of evolved since then.
Fantastic. Dr. Kumar?
So I'm a pediatric hematologist-oncologist by training, and I was actually, just like Dr. Canna, a fellow in my training when I came across this entity, and was quite fascinated by it, but for the longest time, it was not one of my main interests until I was recruited to Cincinnati Children's Hospital by one of the leaders in the field of HLH, the late Dr. Lisa Filipovich. And it was after coming to Cincinnati that I became even more interested, and after seeing a few patients and recognizing the mysteries and the challenges that surround this condition, I became totally mesmerized and entrenched into it. And so that was my unintentional entry. That was never the focus, but now I'd say for the last 10 plus years, that is what has become one of the main occupations of my clinical career.
Thank you both so much for sharing a little bit about how you got started in all of this HLH universe, as we call it. So when it comes to diagnosing HLH, there's a lot that we can talk about. So I think it's probably best to start at the beginning. Could you both speak a little bit about, and even speak to each other, about why it's so important to arrive at the correct diagnosis for patients with HLH as quickly as possible? Dr. Kumar, we'll start with you.
Well, HLH is a serious life-threatening condition, and if the diagnosis is delayed, we know that the consequences can be catastrophic. So there is urgency, but along with the urgency is the accuracy, because if the incorrect diagnosis is made, and by that, my main concern is that the current prevalent ways of making the diagnosis rely on criteria that are quite nonspecific. And historically, up until maybe 20 years ago, the concern was that people did not know about HLH, so never got to the diagnosis of HLH. I think that pendulum has swung a little the other way now, where many other conditions that may look like HLH get diagnosed and treated as HLH, leading to disastrous consequences. So so it is quite important that, one, the diagnosis is not delayed too much, but at the same time that the diagnosis is made correctly and in a timely manner. Both are important, because either way the consequences can be quite disastrous.
I have zero disagreements, which I know we're supposed to be manufacturing conflict, but I do look at this a little bit differently, and part of that is just because, like, I am by nature a bit of like philosophical navel gazer, and so the first lens is really like the history of medicine, and you can't disentangle almost anything that we use diagnostically from sort of where it came from. And so the term HLH, which is this mouthful of hemophagocytic lymphohistiocytosis, comes from back before there were any of the biomarkers we'll talk about, any of the genetics we'll talk about, when it was just a really sick patient and somebody with a microscope, and they said, I see these hemophagocytes and I see these lymphohistiocytosis, and so that's what we're going to call it, regardless of etiology, and then we will, treat it with leeches or, I don't know, lead or whatever they were using at the time. And, for better or worse, that's sort of what has stuck to the name, despite, it was 1999, I think, when the gene...
Perforin was first identified.
Genetic deficiency of perforin was associated with HLH.
Right.
And so it has evolved to be this thing where we don't even know what we mean when we say HLH sometimes, because we mean two different things. And I think that conflation of those two different things is a problem. And so one of those things is it kind of gets into this, what do you mean by a diagnosis? I know, like, what is a diagnosis can be a description of like what a patient is doing at the time, or it can be what we hope it to be, which is a sort of description of how you got to that place, an etiologic diagnosis. And so the criteria don't circumscribe an etiologic diagnosis. They describe a immunophysiologic state in time. That we now understand there are dozens and dozens of different ways of getting there, and that you definitely don't want to treat them all the same, because you'll do a lot of harm and you'll miss a lot of things. And so, there has over time been efforts to try to add precision by modifying HLH to malignancy-associated HLH or secondary or primary or familial or whatever. But, things are busy, things are complicated. And sometimes we just say, oh, I think that they have HLH. And you're kind of like, well, do you mean that they have this immunophysiologic state that we should sort of respond to in a general but safe way, recognizing that there's complications and it builds a differential diagnosis? Or do you mean that they have this one specific pathway of getting there that suggests a very specific course of treatment that you wouldn't want to use for the other half dozen?
So there is this maze and mess of terminology that, for lack of, not to sound too esoteric, but that is the truth. And things are a lot more complex than we would like them to be. They're just not as simple as do you have HLH or not? And if you do, is it primary or secondary? It's a lot more nuanced and a lot more complicated than that.
So the way a patient's condition can rapidly deteriorate is a clear indication of why that prompt diagnosis is important. As you mentioned, Dr. Kumar, the urgency is important, but the accuracy, as you mentioned, is also important. And that's not always easy, because if there's other conditions which, at play that might be mimicking the HLH is one way of saying it, some treatment strategies could actually harm the patient rather than help them. So we'll go into more detail about the conditions that can look like HLH later. And if we talk about them along the way, that's fine too. But for now, let's get a little bit deeper into the diagnostic process itself. So this HLH 2004 diagnostic criteria that we've referenced a few times already, they were developed to enroll pediatric patients in a clinical trial to study primary HLH. And there are 8 criteria overall, but the current paradigm is fulfilling 5 out of the 8 is suggestive of this primary HLH. So I know there's been a lot of debate about this subject among physicians, perhaps among yourselves, and researchers all throughout this field. So let's walk through, and maybe you could help us a little bit walk through this HLH 2004 diagnostic criteria, share your insights on how you manage those criteria and use them in your practice to assess your patients. Dr. Canna, let's start with you.
I think that the criteria are not so bad. I don't think that they're going anywhere for better or worse, based on some forthcoming publications that I know about, but I'm not driving. The problem is really what's on the other end of the criteria, which and here I think Ashish and I, or Dr. Kumar and I agree completely. So the parallel I always draw is to this other syndrome called shock, which is acute, life-threatening, bad, and not uncommon. And it's, perhaps the reason that we have intensive care units to begin with. And so, there are criteria for shock, and it is a diagnosis. But by no means would anyone ever say, you have shock. There's one treatment paradigm that we use for that. And there's at no point that anyone would say, you have shock and it's only being caused by this one thing. We immediately understand as physicians, when we say shock, we mean a physiologic process where you're not sending enough oxygenated blood to your organs. That's the physiology. So the criteria reflect that physiology. And we get that, if your heart doesn't squeeze well enough, that's going to contribute to shock. If you're septic and your blood vessels are all dilated, that's going to contribute to shock. And so, I look at the fulfillment of the criteria a little bit like that, where they tell you that there's a certain physiology going on. And the immunophysiology, at least that I take away from it, is roughly a physiology of overwhelming T cell activation, and what goes along with that, and some of the biomarkers that go along with that. And so, I think the criteria are useful for saying, okay, there's physiology like that going on. There's this threshold in that physiology that we call fulfillment of the HLH criteria. And so not only do I recognize that means that this patient could be headed in a certain direction, so I'm going to be prepared with my monitoring and looking out for certain things, but it's also going to build a heuristic in my head of, here are the diagnostic categories, here are the things that kind of are for my geography or for this specific patient's demographic, likely to be driving that kind of physiology. And then I got a couple of things that I can use that are helpful for almost everybody who's in that physiology. But I fully understand that at the basis of all of that is understanding and treating whatever's driving it.
Going to take one disagreement here. And that is, I think the criteria overall are suggestive of HLH, but this concept of 5 out of 8, that has caused more harm than benefit, at least currently, because I agree that HLH at its heart has to have excess T cell activation. That is the underlying basis of it. But the 5 out of 8 choice leaves enough room because there are some markers of those 8 features. I am referring specifically to the soluble IL-2 receptor. That is the only one that is specific to T cell activation, and that is left out as an option, which means we have seen patients who fulfill the other 7 criteria, but the soluble IL-2 receptor was normal. But guess what? They were diagnosed and treated as HLH because they met the criteria. Additionally, the NK cell function, which is part of those criteria, it is based on a chromium release assay. We know that if a patient is sick from anything, even a cold virus, the NK cell function result will come back as abnormal, so it is completely unreliable. And third one is the feature that lends the disease the name, hemophagocytosis, is also completely nonspecific. You will see it in almost every patient who has infectious mononucleosis. Our pathologists can find it in almost every patient with a leukemia or lymphoma. And so when you have such non-specific features added, the biggest one being that soluble IL-2 receptor, or a marker of T cell activation, is a choice. It's not mandated. So by that means, these criteria are quite flawed and should not be used the way they're currently accepted. Now, if we keep the features the same and say that you must have elevated soluble IL-2 receptor, that is one possibility. But then that gets to the challenge of, well, that assay is not available everywhere. It's definitely not available on a Friday afternoon when most of these patients do present. In which case, instead of calling them diagnostic criteria, I should say, if you relabel them as suspicious criteria, I think that would be more accurate. And although I agree that these criteria just describe a state of inflammation, just like shock, the one place where that conceptualization, I think, diverges is that every patient with shock, if you give them fluids or vasopressor agents or medications that squeeze the heart a little stronger to improve the circulation, that will help every patient with shock. Unfortunately, some of the anti-inflammatory drugs that are used to control the inflammation, if you give that to patients who have disorders that mimic HLH, you will actually cause the death of the patient, which is what has happened in several of those patients. So while I agree that the analogy to shock is accurate in getting to the description and the concept of what these features describe, it ends there. When it comes to actually management, we have to be a little more careful. We need some more clarity. And yes, I don't think these criteria need to be discarded. No, because they do help, but they need to be revised, or at least maybe reworded in some ways to change the fact that not each feature carries equal weight, and that some are more important than others. And no matter how many criteria you meet, they're not the end all of making the diagnosis of HLH. They get you to the suspicion. And we do want clinicians to then use some clinical judgment, because if it's happening on a Friday evening, you're not going to be able to get any of the sophisticated assays until the week after. How do you keep the patient alive and well in the meantime? And also, if I may add, I know you did not ask me to, but I'm going to finish with the fact that if at the end, or if after confirmatory diagnoses, primary HLH is not proven, it doesn't matter how many criteria are met. You need to pause and go back to the drawing board to see what did we miss. That is also not included in the criteria. Also not included in the criteria there are features that go against HLH, but they're not mentioned in the criteria. For example, an elevated white blood cell count. Nowhere in the criteria does it say that if you meet 6 of these criteria, but you have leukocytosis, it cannot be HLH. It's rather more likely you're dealing with either an infection or leukemia. Nowhere in the criteria does it say that. So for these reasons, I think they do deserve to be revised. They should not be implemented the way they're currently written as being diagnostic, as if giving permission for clinicians to say, yes, you can diagnose HLH and start therapy based solely on these criteria the way they are written.
Mm.
Sorry, Scott, I had to disagree with you on that one.
Well, I think, yeah, I'm going to take your disagreement as an agreement. So some of the issue is we come from different worlds. I'm a rheumatologist, and we have, criteria for our diseases, but sort of the underlying foundation of all of those criteria is that we don't actually know. And so, there are no criteria within rheumatology that sort of land you in a place of certainty. And every one of us has dozens of patients who have met, whether it's lupus criteria or whatever, that have something else, or they have that thing, but there are complicating factors. There are other reasons they are anemic, but it's not a hemolytic anemia. It's another thing of the anemia. So we don't really trust any of our criteria. And so, I think that, and we also don't really have a lot of protocolized treatments following those criteria anyway. So whether one meets criteria or not within the very smaller world of pediatric rheumatology rarely indicates, oh, we're going to put you on a pathway. Whereas, I should let Dr. Kumar talk about, the pediatric hem-onc approach, for very good reason, has here's the diagnosis, and you enter this protocol, and pediatric leukemia has gone from a death sentence to, whatever, 90, 80% survival. So it's working for them. I think we've sort of conspicuously not mentioned ferritin, which I think is in increasing use. I think that it is a very good biomarker within the limits of understanding that it's a sensitive biomarker, meaning if you're worried somebody has HLH and their ferritin is 400, it's not HLH. It's at least not HLH yet. If you're really concerned, check it again. But that there are lots, again, of other ways of getting to a high ferritin. And this is another place where our worlds somewhat differ. It's uncommon for a rheumatology patient to be getting transfusions constantly, to be having lots of reasons for sort of baseline T cell activation. And so a ferritin of 1,000 in our patients is uncommon enough that it really sort of triggers. Whereas, other non-HLH drivers of high ferritin, like iron overload from frequent transfusion, like someone who maybe has just had some sort of a transplant or chemo and they're repopulating their immune cells. And so that's driving a little T cell activation totally remote. So all of these things, these criteria, and I totally agree with Dr. Kumar that the thresholds really need to be reset based on the context of the patient you're looking at. And that's why, the ferritin cutoffs within like the H score, which is derived from adults that have mostly infections and cancers, a level of 500 is not particularly useful in that context because there's lots of other ways of getting to 500 in that population. Whereas in otherwise healthy children, 500 is maybe an okay threshold. So yes, I agree that calling them diagnostic criteria is not doing our colleagues a favor. But whatever the right term is, suggestive criteria, or the other thing I'm always on about is that these biomarkers that we use, no biomarker or almost no biomarker is diagnostic. They all they all recognize like physiologies, which also means that you can have patients, and we have had a number who have familial HLH and they don't meet criteria yet. And to be honest, neither they nor their parents really would like you to wait to intervene until they do meet all the criteria, because at that point it might be a lot harder to turn things around. So I think all of these things are reflective of sort of vectors of physiology, if you will, that whether they meet criteria or not, you have to still apply some scrutiny to.
Well, I mean, it definitely sounds like these HLH 2004 criteria are being used to help guide this diagnostic process, or as you said, Dr. Kumar, a suspicion of HLH. But there are obviously, based on this conversation, it sounds like some very important considerations that need to be weighed carefully when applying them to patients who may have additional underlying disease processes affecting them. So I understand that genetic testing, which we've sort of touched on and just, in our conversation just referenced a little bit already today. And then additionally, flow cytometry. Dr. Canna, you just mentioned biomarkers. All of these types of things can also play a hugely important role in what a clinician is trying to do in identifying what's going on, whether it's HLH or something else. So can you tell us more about how these types of things, genetic testing, functional assays like flow cytometry, biomarker testing, also fit into this diagnostic journey, this diagnostic process, and how you each incorporate them in your own practices? Dr. Kumar, we'll start with you.
Yeah, so I think we need to trace back to 2004 when these criteria were developed. Actually, that's when the clinical trial began. My suspicion is that they were conceived before that. And as Dr. Canna was mentioning, it wasn't until 1999 that the first gene, perforin, was discovered as being one of the mutations that leads to primary HLH. The second gene did not come into light until 2003. And the mechanisms of all these other genes coming together as being how they all are involved in the degranulation of the perforin-containing granules, that was not understood until many years later. And so we now have a much better understanding than we did 20 years ago in 2004. That has what has led to us starting to incorporate some of these features. So as I mentioned already, soluble IL-2 receptor, if that's normal, HLH is off the table for us. Because you don't have T-cell activation, you can't have HLH. Okay, so starting there, and then starting to incorporate, now that we know all of the genetic mutations that are seen in primary HLH, whether it is the perforin degranulation pathway, which makes up the bulk, or what is called the FHL category, but combined with that are some of the other more recent additions to the pathophysiology. Dr. Canna is the leader in that field, and that is the inflammasome dysregulation disorders. All of these can now be assessed using flow cytometry assays, which are very specific, quantitative, and turnaround times much shorter than majority of the genetic panels. However, the challenge is that they're not available at every institution, but they are available at enough numbers of institutions, at least in North America, that every center can send them to any of the centers which run these assays, and the results will be available in the next 48 to 72 hours. So, for example, you can measure by flow cytometry perforin, the expression of perforin itself, the movement of the lytic granules from inside to the immunologic synapse. That assay measures the function of 7 genes that have known to be identified as being mutated in primary HLH. You can also, by flow cytometry, measure the presence of the 2 X-linked proteins, SAP, which is mutated in XLP1, and XIAP, which is the inflammasome associated gene, mutated in, some people call it XLP2, we just call it XIAP deficiency. But if you do these 4 flow-based assays, so if the soluble IL-2 receptor was elevated, then we move on to these 4 flow-based assays, and if those are all normal, we have essentially ruled out all the known genetic causes of primary HLH. That then leaves, are there other unknown genetic causes? I'm sure there are. We have just scratched the surface of the knowledge about the human genome. No question about it. But now we're venturing into the unicorns among zebras, because primary HLH is a rare disease to begin with, and more common than HLH would be things like disseminated viral infections, bacterial infections, lymphomas, leukemias, which can fulfill the HLH criteria, HLH 2004 criteria, just as well as primary HLH can. So the investigations have to include both primary HLH and all of these categories simultaneously, not in sequential order, because the longer you wait, the harder the patient's condition might deteriorate. And unfortunately, if someone intervenes with therapy that is aimed at primary HLH and the patient actually had a leukemia or lymphoma, now you've masked or even lost your ability to make an accurate diagnosis. So for these reasons, we incorporate not just these flow-based assays, but many of the other things as well at the same time in pursuing the diagnosis in a patient who manifests the clinical features that are listed in the HLH 2004 criteria.
I think that was a really brilliant summary of where we're at. I do want to talk about where I think that the field should be headed shortly. So one thing to say is that medicine has always responded to complexity with specialization. There didn't used to be a field of pediatric rheumatology, and then we discovered stuff, and then it just got too complicated for a general pediatrician to manage, that we don't have rheumatism anymore. We have 12 different kinds of rheumatism. And I think that slowly this is happening within HLH, where just, really good rheumatologists, hem-oncologists, are just, things are developing at a rate where it's not always reasonable to expect people to have a lot of familiarity with when to send X, when to send Y, who's running it where, I think this is especially true with the biomarkers like soluble IL-2. I think people are really coming around to, but a lot of places are still trying to figure out when to send a ferritin. And the answer is always, it depends. And so, one plug I'll make, I guess right now is really like, I think that it is increasingly incumbent on centers to have kind of like a HLH response plan in-house. It doesn't mean that they have to have a multiply R01 funded whatever to lead that. It just means they have someone who that is their specialization, just like, hematology and oncology are increasingly splitting because there's just too much for this Cro-Magnon brain of ours to wrap our heads around. I make a distinction between familial HLH and primary HLH, where familial HLH is a subset of primary HLH, where familial HLH specifically refers to those genes that affect the granule-mediated cytotoxicity pathway, which is the best worked out and really elegant work over the years, and an increasing number of genes, and in that pathway, both the genetics and the functional tests are useful because you may have someone who has Rho-G deficiency. Okay, well, it was only 2.5 years ago that we didn't know that Rho-G deficiency was a cause of familial HLH, and that's how this stuff works. And so, but you might have a patient who their genetic panel is fine, but their degranulation assay is all wrong, and you say that patient has familial HLH by some gene that we haven't found yet, or by some mutation in a non-coding region or whatever of a gene we do know about, but it's a fancy thing. We'll figure it out later, but this is what they've got. So I think there's a role for both genetics and functional testing. But there are forms of primary HLH which are not, there is no functional test for. So I was involved in discovery of this gene NLRC4, which is an inflammasome-mediated thing, and we don't have a functional test for that. If you want to know if somebody has an inflammasome thing, then you have to do the gene, or there's a decent biomarker called IL-18, which is sort of the basis of what my lab tries to understand. But certainly IL-18 is not specific for NLRC4, and is a vast minority of the patients that have HLH that IL-18 is a major contributor. So I guess I want to ask a question for Dr. Kumar. If you could get a I mean, ideally an exome, but let's just say one of the, 4 to 500 gene immunodeficiency panels, if you could get a, let's say, 48-hour turnaround time on that reliably, would you even send the functional testing?
Yes, because you know what's coming next. The report comes with a VUS, a variant of unknown significance, right?
Yeah.
And so what do you make of that then? And so that's where you need both. Now, of course, if they come back with the known pathogenic mutations that are well described in the literature and you find biallelic or homozygous, then of course it makes perfect sense. But if you find one that is known and one that is unknown, or one that if it's never been described, or if they don't report one because it was in the intronic region, that's when the functional assays come in. So I would not give up, but perhaps if there was a 48-hour turnaround time, and we know that there is one company that does offer that.
Sorry, I meant like a widely available, economically feasible.
There you go. Accessible, readily available, as easily as perhaps ferritin. We could start with such a gene panel, and if there's ambiguity, then move on to the functional assays for the ones that do exist. If it's straightforward, then perhaps the functional assays are not quite as important.
Yeah, I mean, I was sort of setting you up. I hope we are moving towards a paradigm where, like, we get the genes. If they're not diagnostic, then we can send the functional assays. But just like we get lots of variants of unknown significance, we also get lots of functional assays where it wasn't handled properly. There aren't enough white cells. There's contamination from other things that makes it hard. We should send it again. And so, we get that less with the genetic testing. I think it's uncommon that we get harmful results. We just mostly get confusing results out of the genetic testing. And I think that, again, it comes with this specialization to have the level of comfort to say, okay, there's always going to be interesting things in the genetic report, but nothing that's actionable imminently. Let's move to functional testing or more biomarkers, whatever.
I'm wondering, are there any other additional biomarkers that may be available to clinicians out there that are not mentioned in the 2004 guidelines?
Yes, there are. I fashioned myself a little bit of a biomarker guy, mostly just because that has been important for what my lab does. But, insofar as those criteria are to help define this sort of syndrome of HLH, as sometimes people call it, we're looking for biomarkers of T-cell activation. Dr. Kumar mentioned this soluble IL-2 receptor, and I think, increasingly turnaround time is going to be better on that. There's another one called CXCL9, which is a chemokine, which used to go by the name MIG, which is monokine induced by interferon gamma, which is kind of a nice clue of like what we use it as, which is a biomarker of interferon gamma. Interferon gamma is like one of the main cytokines made by the kinds of activated T cells that tend to drive HLH. Almost every cell in the body can respond in its own unique way to interferon gamma. And one of the ways that it responds is to make this chemokine called CXCL9. One of the nice things about it, I guess, is that it's incredibly dynamic, meaning, the normal levels can be in the range of a few hundred, and you can measure it in patients all the way up to almost 1 million. And those levels are quite dynamic in time as well, meaning if you came back to that same patient after initiating appropriate therapy, it might be much, much, much lower 24 hours later. The problem currently with 6CL9 is we get the result back a week later, at which point the 6CL9 level is guaranteed to be different than when we send it. We just don't know in what direction. So sometimes we're ordering another one before we have the result of the first one, just so we can kind of keep the wheels running. Some people might wonder, like, why not just measure interferon gamma directly? Great question. The answer is, like everything, it's complicated, but it's often, there are a lot of assays out there that are not super sensitive. And so you can have a decent amount of interferon gamma activity and floating around, especially it might be in tissues and not necessarily in the blood. And the level on a cytokine panel may be normal or may be sort of trivially elevated. So those, I think, are the main ones. I'll stop there and see if Dr. Kumar has anything, but I do want to circle back to maybe one other cytokine.
I think that's exactly it. CXCL9 is probably the newer, probably a little more specific and newer biomarker. So I think we can leave it at that.
Well, there is one more that is a little dear to me, which is IL-18.
IL-18, of course. Of
course.
So
it does not belong in the criteria because the majority of patients that have HLH, whether you mean primary HLH or whether you mean the syndrome of HLH, will not have a IL-18 level that is helpful. But there are a small number of causes of the syndrome of HLH, specifically those that tend to cause the rheumatic HLH that we call macrophage activation syndrome, again, for historical reasons, in which case most inflammatory biomarkers are fairly nonspecific. On IL-18 level above a certain threshold, and again, it is a little context dependent, but most people would say if it's above 20 to 40,000, you're probably dealing with something in the ballpark of Still's disease, systemic JIA, or one of these genetic autoinflammatory things, including XIP deficiency. And so, it's not a great monitoring biomarker. It's good for monitoring very long term, but in the short term, it kind of is up and stays up. But there aren't a whole lot of things that will give you an IL-18 level of 100,000. And, in our Still's patients, we see 100,000, 200,000. I think the highest we've seen is close to 1 million again. So again, a really broad dynamic range. And unlike most of the things that we send, a pretty decent diagnostic specificity.
Agreed.
Amazing. Thank you both. I mean, it's really so helpful to hear how you use all of these tests to help narrow down or make a diagnosis efficiently. I think all the progress that's been made in all of this testing and all these methods for identifying HLH or whatever else is going on is absolutely fascinating. It shows how the researchers in the field are learning more every single day. We're learning from each other. And this measurement of CXCL9 as this emerging biomarker for HLH disease is particularly interesting because it may have the potential to help identify patients sooner before if it becomes more accessible. So next, I'd like to talk a little bit more in detail about some of these, may call them disease mimics or something else that might be going on that looks like HLH, other conditions that can be confused with HLH. From what we discussed, it's extremely important to rule these out, obviously, as a potential source of this HLH-like presentation. So in your experience, what are some of the most common conditions that can be confused erroneously with HLH? And how can some of the testing and assessments we've already discussed be used to uncover what's really going on? Dr. Kumar?
Well, I'm going to jump in because I want to structure this. I'm not going to answer your question, but I'm going to frame it a little bit.
All right.
Which is that there are no cases of HLH where there's just one contributor. I think that by and large, people should think that we don't always find all of them, but we should expect that so to back up a little further, if you do research in model systems and you have an organism or a cell that is perforin deficient, everything is fine. Perforin deficiency by itself does not drive HLH in a model system. You've got to perturb it. You have to make it need perforin, almost always using some sort of infection, a virus, in which case things go completely haywire. And so, I think I use that as an example of saying, like, even if you have someone who has primary HLH, if things are not going according to plan, you should be thinking about the other things that contribute to HLH that may have popped up in that patient additionally. You have a primary HLH patient who's in the hospital filled with respiratory viruses. You should think about whether they've contracted, HMPV or RSV or something, and that is sort of complicating the course of things, even though the main contributor has been identified. So I would say, like, HLH is always sort of a cast of characters. Sometimes there's one really primary thing, but other times, even over time, there's sort of a complex melange of contributors. The one that I'm not even sure belongs under the moniker HLH, but often meets criteria, are patients with severe sepsis. But Dr. Kumar is really sort of the global expert on identifying and suffering through a lot of primary HLH mimics.
So, well, Dr. Canna, while I agree with you, the framing on that, but I think we owe it to our clinician colleagues who are not as deep enmeshed and mesmerized or in love with HLH like you and I are. We owe it to them to try and keep them away from the research controversies and out of the weeds a little bit, to give them some practical tips on what to look for. So I'll get back to you on the difference between the model system, the humble little rodent, versus the complex human. But getting back to Adam's original question of what are the mimics, and I broadly categorize them as ones that do involve T-cell activation and those that don't. So if you're going strictly by the HLH 2004 criteria, which other conditions will fulfill those criteria if you're going by the 5 out of the 8, or the H score for that matter, which relies on the same biomarkers but assigns weightage to them. So if the soluble IL-2 receptor is elevated, often there will be lymphomas, leukemias. They will all have elevated soluble IL-2 receptor. In fact, soluble IL-2 receptor, the test, the soluble CD25, was originally thought of as a prognostic marker for Hodgkin's lymphoma, because that is where it was first recognized as being elevated, because in Hodgkin's lymphoma, there is activation of T cells. In almost all lymphomas, there are activated T cells, whether it's a B cell lymphoma or a T cell lymphoma. Okay, so depending on the age of the patient, so if we're dealing with a teenager or a young adult or an adult for that matter, a malignancy such as leukemia or lymphoma are more likely than primary HLH. If you're dealing with an infant, if there was a family history of primary HLH and you have an infant who has a fever and abdominal distension with an enlarged spleen, it is primary HLH until proven otherwise. Now, if you're dealing with an infant in whom there is no family history, then we have to start with a clean slate, and anything is possible, but we have to remember that infections are still the number one leading cause of infants landing up in the ICU, or infant mortality, or children getting sick. Infections still remain the most common. Then come malignancies such as leukemia, lymphoma. We don't think of cancer in children, but believe it or not, there are somewhere between 2,500 and 3,000 children who get leukemia each year in the US alone. And those numbers are significantly higher than those children who will get primary HLH. So keeping these things in mind, just the odds of these things being higher. So infections, malignancies, and depending on the geographic location and time of the year. So for example, if you are in the Northeast, histoplasmosis is common. If you go to the South, the middle south of the country, zoonotic disorders like infections like ehrlichiosis is common. And if you go to the Southwest, Rocky Mountain spotted fever, those kind of rickettsial diseases become more common. These type of infections, based on the geographic location, must be considered, and the age of the patient. So infections, malignancies, and of course, macrophage activation syndrome. You cannot forget that one. And of course, now if you start reading the papers, you will find, name the disease, it has been shown to fulfill the HLH 2004 criteria. Side effects from medications, this thing called the DRESS syndrome. You name the infection, you name the medication, it has been associated with fulfilling the HLH 2004 criteria. So anything is possible, but the ones that you don't want to miss are malignancies and infections probably the most important ones.
Thank you for that. Dr. Canna.
Dr. Kumar sort of hinted at drug reactions that cause HLH, and maybe the most common right now is a very expected drug reaction following like CAR T cell therapy, which for all the world, it goes by another name, of course, cytokine release syndrome. Although if it's really bad and sort of biphasic cytokine, the second part we call CAR T cell HLH, which So I think that the physiology of overwhelming T cell activation applies broadly in a lot of contexts, and is a good way to conceptually anchor these things. We have, over time, and especially recently, had a number of patients who have incredibly high ferritins, do have quite high soluble IL-2 receptors, and appear to all the world to be incredibly septic, in whom it's unclear how much T cell activation is the main driver of what's going on, despite there being some T cell activation. And so there are fringes where even the well-meaning concept of secondary HLH kind of falls apart. And in those patients, and this is part of the reason why we have these HLH response teams, is because those are exactly the patients where things are very confusing. There's more than one physiology happening at one time, and the different specialties need to learn to sort of work well with each other in real time, because there's a question about HLH, there's a question about sort of shock and tissue damage, there's a question about thrombotic microangiopathy and DIC, and some of those hematologic things that come into play and have empiric therapeutic consequences. And none of these physiologies are mutually exclusive. And so, we use biomarkers to try and tease them out. But especially these like incredibly sick septic patients is where a lot of them seem to converge, and decisions about how much immunosuppression versus, pheresis or other kinds of things are necessary.
Since you brought it up and it was an older point, sorry, Adam, I'm going to take this opportunity to talk about one thing. We were talking about thresholds. Ferritin. There is no threshold of ferritin that is specific to HLH, no matter how high. I have seen the highest ferritins I've actually seen have been in disseminated viral infections, virus sepsis, much higher than HLH actually. And in fact, there is literature out there showing that 70% of patients admitted to the ICU will have elevated ferritins. So it is a very non-specific marker of just organ.
They all have secondary
damage.
HLH.
By that definition, sure.
This is the reason that we're having this podcast, is because, when you look for patients who meet HLH criteria, you find them.
You will find them.
And so, it's this challenge of like, okay, well, you've applied the criteria, now what are you going to do?
Yeah.
And if your response is, I'm going to treat it like primary HLH.
Yes. Which is what, unfortunately, because our colleagues are not histophiles like you and I are, is that the right word?
It is now.
It is now. They don't spend all day thinking about these things. They're more concerned about, I've got this patient in front of me, and what do I need to do? And so that's why we have to clarify some of these confusions and update the guidelines.
Yeah, and I couldn't agree more. I do think that guidelines only take us so far. And,
yes.
And, we've talked about this a bunch. Within my sort of piddly role within the Histiocyte Society, I sort of went through and said, okay, well, how many guidelines efforts has the Histiocyte Society or related societies gone through? And there's like close to a dozen. And, within each of those, never does it say, if you meet criteria, you should get the HLH 9404 treatment protocol. But we both experience that happens, and it's understandable. So I think that there's a limit to how much guidelines will do, and I think that we can somewhat take clues from other situations where guidelines have not always served communities, and those are things like sepsis or like stroke, where increasingly institutions have said, when these things come up and there's uncertainty both diagnostically and about what the first step should be, people have to have somebody to call. There needs to be local resources in semi-real time that people can access to say, all right, I have this patient, I'm worried about them, they meet these criteria, what do you think? And there can be levels of escalation. The local response may say, okay, I'm not exactly sure, what's my next level response? I can reach out to the response team at Cincinnati or Texas Children's or, wherever. But I think that those kinds of, just like we do, if someone comes into the ER and you think they're having a stroke, things get activated very quickly because you can't give everybody TPA, but some of them really need it.
I just want to see a poster with Ghostbusters uniform.
Histophiles, who are you going to call?
Who are you going to call?
There you go.
Make t-shirts.
Oh my goodness, this has been so good. So much here, and it's clear that it can be quite challenging to get to the bottom of what's going on under these extremely dangerous manifestations in these patients, especially when so many of them are rapidly deteriorating. It's such an important topic to cover, so that we make physicians aware of what these other underlying pathologies could be that could be at play, and keep them top of mind. So thank you, Dr. Kumar, and thank you, Dr. Canna, for that discussion. It's going to be very important when anyone is suspecting that a patient may have HLH, that they understand some of these other aspects. We have covered a lot of information in this conversation so far, and I really appreciate your insights into the process of making an accurate diagnosis. I hope we've laid a solid foundation to help guide this process for listeners and patients so that this can be identified correctly and efficiently. So to both of you, I just want to say thank you. Thank you for all you do for the community. Dr. Kumar, Dr. Canna, thank you for your time that you gave to record this podcast with us tonight. It has been absolutely fantastic. Thank you from the bottom of our hearts.
Thank you, Adam.
That's very generous of you, Adam.
Yes.
It's been a pleasure.
Likewise.
Thanks to all of you who are watching and listening. If you enjoyed the content of this episode, please make sure that you subscribe so not to miss future episodes, and share it with anyone that you think might find it valuable. In our next episode, we're going to explore the topic of managing HLH and the treatment goals for patients who have a confirmed diagnosis. That's all for now. Again, I'm Adam Narloch, and thanks for stopping by.